The broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to the webinar, How Data, Policies, and Culture Impact Cancer in Asian Americans. This webinar is being hosted by the Asian and Pacific Islander American Health Forum and the Asian and Pacific Islander National Cancer Survivors Network. My name is Roxana Bautista, and I am the Chronic Diseases Program Director here at the Health Forum. I am joined with Trish Klema and Mavis Nita of our Chronic Diseases team. The Health Forum is a current grantee of the Centers for Disease Control and Prevention, the CDC, and we are conducting today's webinar to share strategies designed to improve cancer prevention, early detection, and survivorship among Asian Americans, Native Hawaiians, and Pacific Islanders to our intended audience of health departments, hospitals, physicians, organizations, health centers, cancer survivors, and advocates. Today's webinar is focused on Asian Americans. I'm going to hand this over to Trish, who will now talk about the instructions and logistics for the webinar, and then we'll introduce our guest speaker. Trish?
Thank you, Rox. Hello, everyone. I will briefly explain the control panel that you can see on the right-hand side of your desktop. The control panel is what we will be using to collect questions for the presentation. After approximately 10 seconds, the control panel automatically collapses to the right side of your screen with only the Grab tab displayed. The Grab tab is the column of buttons on the left side of your control panel. On the very top is a red arrow that points to the right of your screen. Clicking this will allow you to open and close the control panel. On your control panel, at the lower half, you can see the chat pane. For questions, you will be using the chat pane to ask your questions, and you can choose to send your questions to either the organizer, that's us, or the presenter, Dr. Zul, who will be who can read your questions if you choose to send it to him. You can type in your question on the screen, on the part that says type your message here, and then by pulling down the drop-down menu right underneath it, you can select your recipient. We will be collecting your questions throughout the presentation, and we will have time at the end for Zul to answer your questions. And with that, I will hand it back to Rox, who will be introducing our speaker for today.
Thank you, Trish. We're now proud to introduce our webinar presenter today, Mr. Zul Surani. He is the Saath USA co-founder and our Cancer Survivor Network's National Advisory Council Chair-elect. He brings a wealth of knowledge as a community outreach specialist and health educator, advocate, and community leader, and has worked for many years at the University of Southern California's Norris Comprehensive Cancer Center. We are very fortunate to have him this morning lead us through this informative session. Thanks, Zul, for joining us, and we can begin at any time you're ready.
Thank you,
Zul?
And I'm really happy to be here today and to be your presenter, and I appreciate you inviting me as well. So our topic today is how data, policies, and culture impact cancer in Asian Americans. And I'm going to start by telling you a little bit about the Asian Pacific Islander American Health Forum and the API National Cancer Survivors Network, so that you have a background on our topic and our purpose. The API Health Forum was founded in 1986. It's a national health policy organization, and it focuses on Asian Americans, Native Hawaiians, and Pacific Islanders. It's based in San Francisco. The network is a national network, and it's a network that was founded in 1998 by Susan Shinagawa and the late Reverend Frank Chong. The API National Cancer Survivors Network's mission is to advocate for greater recognition, inclusion, and engagement of Asians and Pacific Islanders on policies and programs that are critical to the health and well-being of our diverse and vibrant communities. So who are Asian Americans and how do they differ? As you can see from the pictures, there's tremendous diversity in our community. And by the way, that's an extremely old picture of me, so I really don't look like this anymore. I have salt and pepper hair now. The next slide, please. And I'll get into the diversity even more on the next slide. So as you can see, the vastness of the map of Asia and the different countries, and if you go to the next slide, Asians are persons who have origins in any of the original people of the Far East, the Southeast Asia, and the Southeast Asia and the Indian subcontinent. And this comprises of many different communities, and this the diversity has tremendous impact in many aspects of health, cancer, health planning, and the way we collect data in this country. And so the next slide, please. In the U.S., the Asian population is the fastest growing U.S. population. If you can see, we've had a 7 million individual growth in the last 10 years. And if this slide also shows the comparison to all the other groups as well. If you can, on the next slide, as you can see that there's 30 distinct Asian ethnic and cultural groups in this country. 60% are U.S. foreign-born, and there's about 2,000 distinct Asian Pacific languages and dialects. And in the U.S., there's 100 of them commonly spoken. And from what I remember, in the Los Angeles Unified School District, there's about 80 languages spoken. And all of this diversity has tremendous impact on healthcare, how we plan resources, language access. There's all these issues that compound when you have diversity. So this is how the Asian population is broken down. And if you look at it, you're looking at Chinese as being the largest, and then Sri Lankan as being the smallest population. So you could see, you know, the gradient from the largest group to the smallest group. Next slide. So the states with the highest proportion of Asian populations are California, New Jersey, Hawaii, and Washington. And so, you know, there's probably more resources available in these states. But as our communities are getting networked nationally, states that have smaller populations are able to share resources and connect with each other and disseminate information, programs, and also help others advocate in policy in different areas. Overall, cancer incidence rates are higher in men than women. African American men, for example, have the highest incidence, followed by white, Hispanic, Asian Pacific Islander, and American Indian Alaska Native men. Cancer incidence rates in African American men are over 2.5 times that of American Indian men. Racial differences in cancer incidence among women are less extreme. White women have the highest incidence rate, followed by African American, Hispanic, Asian Pacific Islander, and American Indian Alaska Native women. A lot of this data is collected by SEER, and as you can see, SEER stands for Surveillance, Epidemiology, and End Results Program. And as you can see, it's reported in the aggregate that when you look at the death rate, overall cancer death rates are higher in men than women in every racial and ethnic group. African American men and women have the highest rates of cancer mortality. Asian and Pacific Islander men and women have the lowest cancer death rates, about half the rate of African American men and women, respectively. Now, the rates for populations other than white and African American may be affected by problems in ascertaining race and ethnicity information from medical records. And so, for example, including misclassification. So this is likely to result in reported death rates that are lower than the true death rate. So then that brings us to our question that do Asian American cancer health inequalities really exist? And you know, the data we just saw was reported in the aggregate. And again, you know, here's another slide that shows the incidence rates and mortality rates amongst Asian, Pacific Islander, Hispanic, Latinos, and American Indians are lower than those amongst white. Mortality rates are also lower, suggesting that differences in risk factors rather than access to screening or treatment may play an important role. So coming back to the real story, and you know, we realize that the real story is in disaggregating the data. It's in looking at a variety of different sources and breaking the data down so that we can see the real picture for each of the different communities, that we can also look at other types of data, be it very local research that's being done, local needs assessments that are being done, talking to community leaders, getting a variety of sources to really help our policy advocacy, service delivery efforts for our communities. So if you look at this, this slide, you can see that the Chinese community, when it's reported in a disaggregated way, you can see that the Chinese women have 12.8% mortality rate in comparison when it's reported in the aggregate. And if you also look at the Japanese men, you see the difference than when it's reported in the aggregate. So at the UICC World Cancer Congress, this was brought up that compared to all other U.S. populations, the cancer burden among Asian Americans and Native Hawaiian Pacific Islander communities is unique, it's unusual, and it's unnecessary. And that the cancers that it's unique because the cancers that are rare or low incidence in the general U.S. population are more common among many of the Asian American and Native Hawaiian Pacific Islander populations. So we're looking at stomach cancer, liver, and thyroid cancer. And of course, while heart disease remains the overall leading cause of death, cancer has been the #1 killer for Asian American and Native Hawaiian Pacific Islander females since at least 1986, and for males since 2004. The cancer burden is also unique. And again, API women were the only U.S. population group who experienced no decrease in cancer incidence and an overall increase in mortality for all cancers combined. And this was reported, this was in an annual report to the Nation on Cancer, and these trends still continue. So the cancer burden is also unusual because it is it's both chronic and it's contagious. So we're looking at cancers that are attributed to, for example, unhealthy factors, and cancers that are attributed to, for example, HPV and hepatitis B and C viruses. And these viruses, if left untreated, can lead to the development of cervical and liver cancer as well. We're also saying that the cancer burden is also unnecessary. So, for example, the hepatitis B virus and HPV can prevent, vaccines can prevent these viruses from developing into cancers. Nobody should really die from cervical cancer. It is preventable. And then, of course, there's the lack of understanding and awareness, and that leads to barriers and for example, lower screening rates, and navigation seems to be proving very effective to help people get better access and preventing late-stage cancers from occurring. And of course, the tobacco companies continue to target Asian and Pacific Islander communities and nations with tobacco products. And of course, children and teens have rapidly rising smoking rates in our communities. So this slide, we're looking at the common cancers in selected Asian men, and this is finally happening, and this aggregation is beginning to give communities a better picture of how they need to develop their cancer control agenda. So when you look at what might be something that the Chinese community is going to prioritize, it may be different from what the Asian, Indian, or Pakistani community will prioritize. So there is no, the cancer control agenda has to be tailored for each community. There is no blanket approach for all communities. And the breakdown of cancer site data by race and ethnicity is really, really helping the communities at the local level. So I'm sorry, well, it's okay, we'll continue. So for example, and this slide also shows the same for women as well, in terms of the 5 most common deadly diagnosed cancers in selected U.S. Asian women. Okay. So if you look at, if you look at Asian, Indian, or Pakistani, the 5th most common cancer is ovarian, and for Filipina, the 5th most common cancer is thyroid. Okay. And for non-Hispanic white women, we'll go to the next slide. Next slide, please. So cancer in selected Asian populations. So for example, when you look at, I think the slides are stuck.
We're trying to fix it so that it can go. You can keep on talking, so we'll make it
sure.
go to the slide.
So for example, when you look at, when you break down the cancer rates in selected Asian populations, when you look at Japanese Americans, both males and females have the highest colorectal cancer incidence rate. Males have the highest colorectal cancer mortality rate. And of course, colorectal cancer are associated with sedentary lifestyles, low fiber diets lacking in fruits and vegetables.
Hi, so you hold for a minute. Sorry everyone, we are losing connection here at the San Francisco office. If you can hold for a couple of minutes, we will just restart. Hold on, Zul.
Yeah, no problem. Thank you.
Right there. Now it's
No. Okay. So we'll keep speaking, and then we'll try to do catch up with the slides. We're trying to fix it on our end.
Okay, no problem. As I was saying, that in terms of Japanese Americans, males have the highest colorectal cancer mortality rate. And of course, both males and females have the highest colorectal cancer incidence rate. And another thing that came out recently was, well, it's been a while, but a detailed study of breast cancer by race and ethnicity in LA County found that Japanese women have the sharpest rising breast cancer rates over women from all other populations. It's believed to have surpassed breast cancer incidence rates for non-Hispanic white counterparts as well. And this was data collected by the California Cancer Registry. It was an analysis that was done from data collected by the California Cancer Registry by Dr. Dennis Deepen, who has the cancer surveillance program in Los Angeles County. When you look at, for example, Filipino Americans, both males and females have the highest rates of thyroid cancer. Thyroid cancer is associated with high levels of radiation exposure during childhood and dietary iodine deficiency. It may also be a factor. For example, for Vietnamese Americans, cervical cancer rates remain high. High liver cancer in males and females, which are associated with hepatitis B and C infections and cirrhosis of the liver. Overall decline in lung and bronchus cancer rates in males and females are happening with the Vietnamese American community. However, female incidence and mortality rates have been climbing steadily. When we think about Korean Americans, for example, both males and females have the highest incidence rates of liver and stomach cancer, again associated with hepatitis B and C infections and cirrhosis of the liver. Stomach cancer is associated with H. pylori infection, a bacteria found in the stomach, in 2/3 of the world's population. With the Hmong community, you're looking at nasopharyngeal, cervical, stomach, and liver cancer that are up to 16 times higher than that for the non-Hispanic white population. So the Hmong community also has the worst survival rates for liver cancer. It's 1 to 2 times greater than the aggregate for Asian American population. So when you look at South Asians for...
Hey, I'm sorry to interrupt. I just wanted to check if everyone is seeing slide 27, if they're all on slide 27.
It's CSC. Or Zul?
Zul, are you seeing slide 27?
I am.
Okay. Thank you. Proceed.
So when we talk about South Asians, for example, the California Cancer Registry showed that South Asians have markedly lower rates of most cancers compared to other ethnic groups. So for example, males and females have lowest lung cancer rates. Is that because of low smoking prevalence? Males and females have lowest colon cancer rates. Is it because the community has a healthy diet or they're not sedentary? And these are all, good research questions. But, just to say that sometimes because of misclassification, one group may be represented more than another group. When you talk about South Asians, it's again in the aggregate. In fact, we have done very local research in Los Angeles County that has found, well, we focused on behavioral risk factors and found that for certain communities like Pakistani and Bangladeshi, for example, mammography screening rates were very low. And so, you know, all of these, a variety of different sources of data can be taken into play when we are making policy and programmatic decisions. So for South Asians, among the top 5 incidence cancers, the rates are rising. For males, lung, bladder cancer, and non-Hodgkin's lymphoma, and for females, it's breast, colorectal, and uterine cancer are amongst the rise. So given these facts, why do, for example, breast cancer statistics more often show API women as having among the lowest breast cancer incidence and mortality rates in the U.S.? And could this explain why some medical providers tell their Asian and Pacific Islander female patients who present with suspicious breast lumps and other symptoms not to worry because Asian women don't get breast cancer? And this kind of aggregate data does mask the real problems within the community and the need for advocacy policy systems change at various levels, be it with providers, be it with state health departments or hospitals. So the key to understanding critical health issues for Asian Americans is even more knowledge of U.S. Census demographics and immigration, and the impact of data aggregation on the collection and reporting of Asian American health and surveillance data. And, you know, making cancer control research and funding decisions pertaining to Asian American and Native Hawaiian Pacific Islander populations based on aggregate rates serves only to create greater disparities. Now, if we look at the past, the Asian American communities have faced a history of racism, and you know, if you look at the 19th and 20th centuries, you'll see you know, humongous injustices that have happened, like internment of 120,000 U.S. citizens and legal residents of Japanese descent, and also this, you know, gross dehumanization of Asians that happened in the 19th and 20th centuries. And when you look at what's happening now, South Asians in particular have been classified as terrorists and suspected spies, and the community has been targeted. For example, Sikhs were targeted for wearing turbans. So this history of racism continues. Next slide. If you look at the waves of immigration into this community, the earlier waves, predominantly from Asia, were of immigrants that came to this country largely because of enduring discrimination. Even though they have endured discrimination, they have high levels of education and income. And even newer Asian immigrants professionals are also doing well. So it's this bimodal distribution. You have on one hand, and then on the other hand, you had the waves of people that came in that were refugees that needed more resources and support. But all of these stereotypes that people have of the Asian community ultimately result in adverse outcomes. So next slide. So immigrant populations are more likely to be socially isolated and holding on to their native cultures. And there's often linguistic isolation as well. So for example, in Los Angeles, there was an analysis that was done by the Asian Pacific American Legal Center that showed that 25% of, for example, Bangladeshi families were linguistically isolated, which means that every single member of that family did not speak any English, and so that has had a tremendous impact on accessing health information, resources, and services. The community also experiences significant language barriers, and immigrants are also socioeconomically disadvantaged. There's higher poverty rates and higher rates of uninsurance, and despite people working, 2 or full-time jobs. There's also culture that plays into Asian Americans' cancer experience. There's, communities that think that physical illness is caused by hot and cold imbalance, sins of past life, imbalance, harmony is more important to maintain with body, mind, and spirit. Physical ailment is caused by the supernatural, and all of these cultural factors play into cancer and cancer outcomes and quality of care that's provided. And this, there's other factors like home and folk remedies. Ayurveda is really still a big practice. People use a variety of different other alternative treatments as well. Faith plays a big part. People look to religion for assistance, use prayer and offerings. We had done research in the South Asian community that showed how influential prayer was in somebody recovering from cancer treatment. And the fact that people knew that there were other people praying for them had a big impact on how they felt, and all of which impacted their recovery. And the next slide shows a list of frequently spoken languages at home as well. And if you look at them, and so this plays into cancer information and the way people access information. If you look at the languages, even though Spanish is number 1, pretty much all of the rest of them are Asian languages. And the next slide looks at the limited English proficiency of Asian Americans. For example, 50% of the Vietnamese population would be considered limited English proficient. And this is U.S. Census data from 2007, 2009. These are estimates. It's pretty remarkable when you look at all the numbers. For example, the Hmong community, Cambodian community, the Bangladeshi community, and the Taiwanese community. So now, language barriers, of course, adversely impact health care and health. Next slide. So again, it impacts how people are able to interact with their providers, with social service agency, what they're able to access. Most of the time, people are less likely to say that they need an interpreter, and they tend to rely on family and friends. And as a result, there's been documented non-compliance with their medication, and also people were too embarrassed to inform their physicians when there were problems. So it's also led to some serious problems in health and health outcomes. And there's also this myth that, for example, Asian and Pacific Islander communities, especially Asian communities, are not affected by poverty. And when you look at the data, it tells you a different story. When you break it down, it really tells you who's most affected by poverty. In addition to that, the uninsured rates as well for Asian American populations are showed on this slide as well. The effect of class and socioeconomic status on survival and mortality. There's a clear pattern in social class differences in cancer survival and mortality. So for example, low SES patients have consistently poor survival than high SES counterparts. And in addition to that, the mortality rates are higher for low SES patients than their higher SES counterparts. The other aspect that's huge is misclassification as well, and that results in inaccurate health data which contribute to inequities and disparities. Sorry, next slide. And this is something that's also faced by Native American communities as well. So why does any of this matter? Because if you look at the projections, cancer incidence is bound to rise. It's projected to rise between 2010, 2030, and 2020 and 2030. And in addition to that, the types of cancers that are projected to increase are cancers that we've not dealt with before in the past as well. So it's a unique profile of what cancers are going to affect our community as well, and that are on the rise. So, for example, we're looking at 165% rise in bladder cancer, 160% rise in prostate, pancreatic cancer, lung cancer, esophageal cancer. And so the demographic changes in the U.S. will result in an increase in the number of cancer cases in the next 20 years. And so continued efforts are needed to improve care for older adults and minorities, which are also on the increase as well. And what I wanted to also talk about very quickly was that there's very little that's available in terms of evidence-based programs for the different Asian populations to address cancer and cancer disparities. There's more available for mainstream populations, and so that's an area that that we need further research on. So in summary of key points, our goal here was to understand critical health issues for Asian and Asian American and Native Hawaiian Pacific Islanders that we need to know. We need knowledge and understanding of census and demographics, immigration of refugee status, and a variety of sociocultural variables. That we need to understand that the population's geopolitical history has had major implications on health inequities, health status, health outcomes, that API that's reported in the aggregate is virtually meaningless, and aggregate data obscures the cancer reality of specific ethnic populations. We also need to know that health policy decision-making based on aggregate rates only serves to create greater cancer health inequities for many of our populations. So what can be done? Well, successful outreach, advocacy, and research. And all of these three efforts with our communities is critical, that we must begin and end with our communities. Our communities must be engaged, and that the diversity within our communities must be engaged, that we need to have Bangladeshis at the table. We need to have, the Hmong community at the table, and that we need to address language access, a huge issue for all Asian communities, as you saw from the LEP slides, that our systems, our hospitals need to be culturally competent. And, this is something that I know all large institutions are struggling with and have a long ways to go. We need to engage in partnerships and collaborations. And again, community-based participatory research, given that there's now quite a few opportunities for funding in this area as well, that it's important for communities to partner with researchers. And researchers are able to navigate with communities the different funders and funding sources and engage in this type of research. And then in the end, be responsive and accountable to all Asian communities we serve. And, we really ask that you join the API National Cancer Survivors Network and become part of our national network and assist us and assist in our advocacy efforts and helping bring our voices to the forefront and voices of your communities to the forefront. Now, I wanted to mention that the webinar, today's webinar will be available on YouTube as well, and that if you have any questions, you can email Trish. Her contact information is on the slide. Trish, I think, is there also a survey? Yeah, there's also a survey that you will receive at the end. So we can now open up to questions.
Hello, everyone. It's Trish. We apologize again for the delay earlier. We were having network issues, but if you have any questions, you can feel free to email me. We have recorded this session for your future reference, and it will be available within a few days on our YouTube channel, which is www.youtube.com/APIAHS. And also, I wanted to send a reminder, you will be receiving a short survey from us when this webinar ends. It will only take a couple of minutes, so please do submit your responses because your feedback will be most appreciated. With that, we just wanted to there are a few questions that were asked, and we wanted to give this to Zul. First is, Zul, how do we identify funders to support research among APIA populations?
So again, I think we talked about community-based participatory research, and that is really taking off, and there's many funders that are now providing funding to do this type of research. And so my suggestion would be to partner with researchers that do this type of population research. And if you connect with the network, we will be happy to put you in touch with leading researchers throughout the country that we're aware of that do this type of research. But if you contact your local institution, there may be researchers that either focus on Asians or have the potential to focus on Asian communities. So I think that's a good question and a good route to go.
The next question that was submitted to us earlier was how do API compare to the large U.S. population for risk factors such as smoking, nutrition versus vegetable and fruit consumption, BMI, exercise? when it's risk factors for cancer screening, incidence, treatment, and mortality. Do you have anything you would like to add to that?
So I guess I could just touch on that because I don't really know the full answer to that. But what I wanted to say that, there's data that's being collected. Well, there's not enough data that's being collected throughout the country, and but there's data that is being collected. For example, in California, we have the California Health Interview Survey, CHIS, that does a really good job of collecting data on each of the different communities on behavioral risk factors, and so that type of data can be easily obtainable by going to the CHIS website, and in some cases, in some areas, because the population is very small, this type of data is not being collected. But I think that in certain areas and when agencies collaborate with researchers, they can collect this type of data as well. That's local, that's tailored to a specific ethnic population. For example, in Los Angeles, we helped collect data for South Asian communities with the help of UCLA's Division of Cancer Prevention and Control Research. And so that was great because it was the first survey that was done in language, in South Asian languages. So this can be done as well. There's one question that I got, and that was, where can I get the most efficient, where can I get reliable disaggregated cancer data? And I suggest that you contact your local cancer registry. In Los Angeles County, we have asked the registry, the Cancer Surveillance Program of Los Angeles, to do very specific data runs for us. And even though in some cases the denominator may not be large because the population may be small, you still get an idea of the number of cancer cases in your area for a particular population. So in Los Angeles, they've done data runs for us, for example, on the Samoan community or on the Bangladeshi population. Okay. Trish, are there any other questions?
No, those are the questions that we have for now. We still have 10 more minutes. If people still have any questions, feel free to send in your questions through the chat pane or the question pane. We have been receiving them. A lot of the questions were regarding the recording of the webinar, and it will be available on YouTube.
And what we'll also do is we'll make sure that the webinar PowerPoint presentations that happened yesterday for the Native Hawaiian Pacific Islander webinar and today's webinar will be made available on our website. And what we'll do is, since you all have registered to be on this webinar, we'll email you the link where to find it on our website. So it'll give us a few days, probably beginning of next week, we'll be able to share that with you. End of next week, we'll be able to share that with you. Okay, so slides will be made available, and the webinar recording will also be made available to everybody. Okay, it looks like we're not getting any more questions. We wanted to just give folks a big thank you, and thank you to Zul for joining us today. We hope you can participate in future webinars hosted by the Health Forum and the Cancer Survivors Network. And if you have any more questions that might come up after the webinar is done, please feel free to email Trish, and we'll try to respond to you as soon as we can. So thank you, everyone, for joining us, and the webinar is now adjourned. Thank you, Zul.
Thank you.
Thank you, everyone.
Bye.